All right, let's jump right in. Today, we're tackling 3 bacterial skin infections that every clinician needs to have down cold: Impetigo, Furuncles, and Carbuncles. Getting the diagnosis right from the get-go is absolutely critical because it dictates everything that follows, from which antibiotic you choose to whether you need to pick up a scalpel.
Okay, so what's the real difference here? It all comes down to depth. Think of it like this. Impetigo is just scratching the surface, a superficial infection right in the epidermis. A furuncle, or boil, goes deeper, taking root in a single hair follicle. But a carbuncle? That's when multiple furuncles decide to join forces, creating this deep, sprawling infection. And that difference in depth? That's everything. It's what separates a nuisance from a potential systemic crisis and completely changes how we manage it.
So here's our game plan for this explainer. We'll start with how these lesions look clinically, then move into the lab for diagnostics. We'll ID the usual suspects, the pathogens, and see what they're susceptible to. After that, it's all about treatment protocols, infection control, and finally, we'll look at what happens when things go wrong and wrap up with a couple of quick cases.
First up, clinical manifestations. This is where it all begins, really, just looking at the patient and knowing what you're seeing.
So, Impetigo. This one is super superficial and incredibly contagious. You'll see these little red spots that turn into blisters, which then pop and leave behind that classic textbook honey-colored crust. You can't miss it. It's almost always on kids, usually on exposed skin, and the good news is they don't typically feel systemically sick.
Next, we have the furuncle, what most people just call a boil. This is a whole different ballgame because it's a deep infection of a single hair follicle. It starts as a tender red lump and eventually becomes a painful, pus-filled lesion. You'll find these in hairy areas and sometimes they'll just drain on their own.
And then there's the carbuncle. This isn't just one boil. A carbuncle is essentially a whole neighborhood of furuncles that have all merged together. This creates a really large, deep, and angry inflammatory mass. And here's the crucial part. Patients with carbuncles are often systemically ill. We're talking fever, chills, feeling truly awful. It's a much more serious infection.
You know, thinking about this massive collection of angry cells in a carbuncle, one of my colleagues once said, "Indeed, it's quite the party, but one no one wants an invitation to." And really, that's the perfect way to describe it. It's a gathering you definitely want to break up, and fast.
Okay, so you've made a clinical guess. Now what? Time for Section 2, Diagnostic Identification. We're moving from the bedside to the bench to get our confirmation.
Getting a good sample is everything. Seriously, you can't just take a lazy swab of the surface. You'll just get skin contaminants. For a furuncle or carbuncle, you need to aspirate pus directly from the lesion. For impetigo, you want that fluid from an intact vesicle. Once in the lab, we played it out on multiple media. Blood agar for just about everything, CNA to specifically hunt for gram-positives, and Sabarod in case we're dealing with a fungus. After incubation, the gram stain gives us our first major clue, helping guide therapy while we wait for the full culture results in colonial morphology.
All right, Section 3, Pathogens and Susceptibility. Our culture plates have got something growing. Now it's time to find out exactly who the culprits are and what they're vulnerable to.
So for Impetigo, the big one, the main offender in about 80% of cases is Staphylococcus aureus. Streptococcus pyogenes comes in a distant second. And here's the key takeaway. S. aureus is also the bad guy behind almost all furuncles and carbuncles. This makes it our primary target for empirical therapy, though, the constant threat of MRSA always keeps us on our toes.
Of course, the story doesn't end with staph and strep. You've got to think broader. Here, hot tub or swimming pool, your mind should immediately jump to Pseudomonas aeruginosa folliculitis. For those really nasty, deep carbuncles, you might be looking at a polymicrobial infection with anaerobes mixed in. And in really specific clinical pictures, you even have to consider the rare but deadly stuff like Bacillus anthracis, pathogens that require a whole other level of lab safety, biosafety level 3.
Moving on to Section 4, Treatment Protocols. This is about combining the right drugs with the right procedures.
When it comes to treatment, you have to remember 2 things: source control and antibiotics. For any fluctuant furuncle and all carbuncles, you have to do an incision and drainage. It's not optional. Antibiotics just can't penetrate a walled-off abscess effectively. Once you've got drainage, you hit it with systemic therapy. Flucloxacillin is your workhorse for MSSA. And notice the dosing. For a deep infection like a carbuncle, we're hitting it hard with high-dose IV therapy for weeks. If you've got a penicillin allergy, clindamycin is your go-to alternative.
Now, treating kids is a bit different. It's not just about adjusting doses for weight. Their potential pathogens can be different too. For example, if you see cellulitis in a child under 5, especially around the face, you absolutely have to have Haemophilus influenzae type B on your differential, particularly if their immunization status is unclear. This completely changes your empirical antibiotic choice.
All right, Section 5, Infection Control and Prevention. Because these bugs are so contagious, stopping the spread is a huge part of our job. So, what does this look like in practice? First, some of these are legally notifiable, like invasive Group A strep. You have to report it. On a day-to-day level, relentless hand hygiene is the single most important thing. Wounds need to be covered. Kids with impetigo? They stay home from school until the lesions are dry and treated. And if you're dealing with a multi-drug-resistant organism, that patient is going on strict contact isolation to prevent it from spreading through the hospital.
Finally, our last section, complications and case review. This is about what happens when these seemingly simple infections are not managed well and decide to escalate.
The potential for things to go wrong is pretty broad. Locally, the infection can spread, causing cellulitis, or even getting into the bone, causing osteomyelitis. Systemically, the bacteria can get into the bloodstream, bacteremia, leading to sepsis or endocarditis. Then you have the really terrifying stuff like necrotizing fasciitis, the so-called flesh-eating bacteria, or toxic shock syndrome. And even after the infection is gone, strep pyogenes can leave a parting gift, post-streptococcal syndromes like glomerulonephritis, where the immune system's response to the bug ends up attacking the kidneys.
Okay, so let's boil this all down to a core concept. Remember this. Differentiating superficial from deep infection is what drives your initial antibiotic choice. And please, don't ever think of culture and susceptibility testing as some kind of academic box ticking. It is absolutely crucial for real-world patient care, especially when you're dealing with severe or recurrent infections.
All right, time for a quick case. Case 1. A child comes in with those classic honey-crusted lesions on their face. So, which pathogens are at the top of your list?
And the answer is B. Those honey-crusted lesions are the dead giveaway for impetigo. And that means you're primarily thinking Staphylococcus aureus and Streptococcus pyogenes.
Okay, case number 2. You have a patient with a painful hardened lesion on his neck. The key finding is that it's formed from a coalescence of several infected hair follicles. What do we call that?
The answer here is D, a carbuncle. Remember, a single infected follicle is a furuncle. But that magic phrase, coalescence of several, is the literal definition of a carbuncle, signaling a much more significant infection.
And that brings us to our final, and maybe most important question. We've talked about the best practices for right now, but these microbes are constantly evolving, so we have to ask ourselves, as antimicrobial resistance continues to change the landscape, how do we adapt our diagnostic and treatment strategies to stay ahead of these common, but as we've seen, potentially lethal infections?